Hello friends, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shonali Chandra, and in today's session we will be talking about postpartum hemorrhage, the causes and clinical management of PPH. I have highlighted my reference code here, that is SHONALI. So if you take a plus subscription of the Unacademy platform, you can use this code to avail a 10% discount on your subscription package as well. Unacademy, my friends, is India's largest learning platform. If you get a plus subscription, you get access to unlimited live and recorded sessions from India's top educators. You'll get daily live classes where you can chat with your educator, ask your doubts and queries and get them solved there and then. So it's like a live classroom experience. The courses are structured keeping in line with the latest NEET PG syllabus. There are also live tests and quizzes which will help you evaluate your performance as you go along. And most importantly, one subscription gives you unlimited access. So you can watch all of the live sessions from all of the faculties who are active on the platform. And even if you miss out on the live sessions, you can always go back and watch the recorded versions from the comfort of your own devices. Top educators are associated with the platform. All 19 subjects which we need to prepare for our postgrad entrance exams, they are covered on the platform. And every now and then, crash courses and comprehensive batch courses, they keep getting launched. So you can check out the ongoing courses in the platform as well. And as far as the subscription packages go, you can choose one depending on your need and requirements. So for those of you who are targeting the upcoming exams and need a crash course, they can take the shorter 3 months or 6 months duration. And for those of you who are targeting the next year exams, they can take the 12-month subscription. It will give you ample time to go through all of the sessions and also leave you enough time in the end to revise. It turns out to be more economical also in the longer run. And for those of you who want a slower pace of preparation, you're in your third year and final year MBBS years and you're also juggling hospital schedules and duties and classes and clinics and everything at the same time, then you can take the 24-month subscription. It turns out to be far more economical in the longer run. And if you subscribe using my code, that is SHONALI, then you can also avail a 10% discount on your subscription package, whatever you choose from. And just to tell you about the free live classes, there are free live classes also on the platform, right? And you can watch them on the live platform, on the Unacademy platform. So recently I've talked about everything about normal labor and abnormal labor. It was discussed in hour-long sessions. So each of these sessions is an hour-long session. You can check that out also on the free platform. And from today onwards, starting on September 12th from 8 p.m. onwards, I'm starting a capsule course on reproductive gynecology, which will discuss all the important aspects of all the gynecological conditions like amenorrheas and menstrual cycle abnormalities, abnormal uterine bleeding, infertility, fibroids, endometriosis, adenomyosis. So everything will be covered in detail in this capsule course. So coming back to the session at hand, where we are going to discuss a very important obstetric emergency, which is postpartum hemorrhage. Sumant, welcome. Janni, good evening. So this session is very interesting. Postpartum hemorrhage is a very, very important topic. If you're a final year MBBS student, it is bound to be asked. If you're a NEET PG aspirant, again, this becomes a very, very important obstetric emergency. One emergency that we cannot say that we don't know anything about. And yes, bleeding, hemorrhage in pregnancy, hemorrhage after delivery, PPH is responsible for most number of maternal mortality cases in our country. So it makes it a very, very important topic. So let's talk about the causes of PPH. So what are broadly the causes of PPH? Now in this session, we are going to deal with clinical scenarios. We are going to see how we identify the various causes of PPH, and we are going to talk about atonic uterus, atonic PPH, and genital tract trauma in detail. So we can have the causes of PPH broadly can be remembered by the 4 T's. We have read that from our undergrad years. So the 4 T stands for tone, it stands for tissue, it stands for trauma, and it stands for thrombus, which we need to remember. And these are your causes of PPH. So the tone of the uterus is not maintained, that the uterus fails to contract. Now, after delivery of the baby, it is mainly the uterine contractions which are responsible for controlling the bleeding, because the middle layer of the myometrium, in the middle layer of the myometrium, which is called as the living ligatures. Why are they called as the living ligatures? Because the myofibrils, they are arranged in a crisscross pattern. Okay, these are the muscle fibers, myofibrils, they are arranged in a crisscross pattern, and the vessels are in between them. So when the uterus contracts and the myofibrils contract and retract and become smaller in size, these blood vessels, they get compressed, and that is a most important reason why bleeding after delivery is controlled. So you can understand that if the uterus fails to contract for any reason, it leads to atonic uterus, and that's a very, very important cause of PPH. In fact, that's the most common cause of PPH, followed by genital tract trauma. Now, genital tract trauma can involve the perineal tissue, it can involve a vaginal laceration or a cervical laceration, or even a uterine tear. So there can be varying types of these genital tract traumas. There can be hematomas, there can be retained tissue. So if any time there is small placental bits or membranes that are left behind inside the uterus after delivery of the placenta, then the uterus fails to contract, and that's why retained tissue also contributes to atonicity as well. Retained tissue contributes to atonicity as well, and that's why it's an important cause of postpartum hemorrhage. We have uterine inversion, uterine rupture, or coagulopathy, which are important causes of PPH, which we are going to consider in today's session. Now, PPH is primarily as primary PPH and as secondary PPH. It has been traditionally described as primary and secondary PPH. So what is primary PPH and what is secondary PPH? Yes, anybody? Hello, good evening, Dr. Musarrat. Let me just have a look at Suman's doubt. Amount of blood loss in episiotomy. Well, amount of blood loss in episiotomy, on an average, nobody has really measured the amount of blood loss. I've not read anywhere what is the amount of blood loss in episiotomy. Usually it is I really cannot say what is the average amount of blood loss. In fact, it's not more than 500 ml. It should not be more than 500 ml, otherwise it would make it as PPH, right? So primary PPH is when the hemorrhage or excessive bleeding occurs within 24 hours of delivery. That is called as primary PPH. And the most common cause of primary PPH is atonic uterus, right? Atonic uterus is the most common cause of primary PPH. And secondary PPH is one that is delayed, that happens later. It happens beyond 24 hours of delivery and is identified usually within the 12 weeks postpartum. Within 12 weeks postpartum. That is secondary PPH. Now, can anybody tell me what is the most common cause of secondary PPH? What is the most common cause of secondary PPH? Yes, Vandana has also joined in. Good evening, Vandana. What is the most common cause of secondary PPH? A PPH which did not happen within 24 hours of delivery but was delayed. What is the most common cause of secondary PPH? The most common cause of secondary PPH is retained tissue. Retained tissue. See, Subhash, if it would be trauma that has happened during the time of delivery, it is bound to get identified sooner, don't you think so? If there's a tear or a laceration or a tissue trauma, it is bound to get identified within 24 hours. Why would it be delayed? Secondary PPH, the most common cause is retained tissue, right? When small bits of tissue remain behind, like small bits of membranes have been left behind, what happens is that the uterus is not able to contract properly and it intermittently relaxes in between. That's why it causes secondary PPH. Moreover, any infection, these small retained tissue bits, they can also get secondarily infected. So infection, endometritis, endometritis, infection of these retained tissue bits can also lead to secondary PPH. Please remember that important point as well. Okay, now moving on further, the next question is, okay, Thumala, which coagulopathy mostly is reason for PPH? I mean, at that age, ma'am. Okay, so coagulopathy, when we talk about obstetric causes of coagulopathy, the most common cause is placental abruption. Okay, coagulopathy meaning DIC. All right, coagulopathy here refers to in the sense that there is DIC. In obstetric cases, the most common cause of coagulopathy or the most common cause of DIC is placental abruption. Okay. All right, so that's the most common cause. Apart from that, yes, of course, you can have inherited coagulopathies as well, but they will come second on. First, I will think of an obstetric cause for a coagulopathy, and then the congenital coagulopathies will come into play. Okay. Now, moving on further, how much blood loss is PPH? Yes, anybody? How much blood loss is PPH? What is the traditional definition of blood loss in PPH? When do we call it as PPH? Yes, anybody? How much blood loss is PPH? Well, traditionally it has been described as blood loss which is more than 500 ml in a singleton vaginal delivery, or a blood loss which is more than 1000 ml in a twin vaginal delivery and cesarean section. Right? Now understand this important point here, that when a woman is having atonic PPH, so you were delivering a woman, you were conducting the delivery and the uterus failed to relax, right? And then you have no time to wait for 500 ml of blood loss to happen and then act upon it. Because see, when a uterus is bleeding, when a uterus is atonic and it's bleeding, you know how much the blood flow through the uterine arteries to the uterus is at term? It's about 500 ml per minute in each uterine artery. So, by that logic, the uterus could bleed massively in a moment of minutes. The woman will get decompensated, right? So, whenever the uterus fails to relax and we are conducting the delivery, we act immediately. Yes, traditionally, blood loss more than 500 ml is always, cited as the traditional definition of PPH, or blood loss more than 1000 ml in twin vaginal delivery and cesarean. But what I want to emphasize upon is any bleeding that looks excessive, any bleeding that makes the woman symptomatic is significant. Please remember, any blood loss that makes the woman symptomatic is significant, because obviously understand that if a woman is already anemic, let's say if a woman is, you are delivering a woman with an hemoglobin of 7 gram percent, okay, and she happens to lose 500 ml of blood, that is too much for her, right? I don't even want her to lose 500 ml of blood before I start acting upon it, right? So any blood loss that makes the woman symptomatic is very, very significant and is considered PPH, and that's a more clinically sound definition to go by. And there's another definition of PPH. PPH can also be diagnosed in retrospect. For example, blood loss that leads to a falling of hematocrit by about 10% after delivery. So let's say, for example, today, you are taking your ward rounds and you send off a woman to the labor room at night, and then you go back home and you come back the next morning and you have a look at the woman, meet her the next day, and you see that she's looking very pale. And you think that I saw her just yesterday evening, she was fine, and I'd sent her to the labor room, and now she's come back delivered and she looks very pale to me. So you check her hemoglobin status and you realize that there is a fall in hematocrit of more than 10% after delivery. That means that she has had PPH during delivery. So any blood loss that makes the woman symptomatic is a more sound clinical way to go about diagnosing PPH. Any blood loss leading to a fall in hematocrit of about 10% or more after delivery is also considered postpartum hemorrhage. Okay, so we're clear with the definitions onto how much blood loss is PPH. Now, moving on further, let's see how we go about identifying the causes of PPH. So, we have the list of the causes with that: atonic uterus, genital tract trauma, right? Retained placental tissue. These are our common causes which we are going to identify. Now, let's see here. You are conducting the delivery of a 35-year-old woman. She is fifth gravida para 4. She is fifth gravida para 4. She is a multiparous woman. She is in spontaneous labor, otherwise no problem. A healthy 4 kg boy is delivered, no problem there as well. Soon after delivery of the placenta is complete, you notice that the uterus is flabby and a gush of blood is pouring from her vagina. The pulse rate is 110 per minute. The BP is 100 by 60 mmHg. So they're not telling you how much blood loss has happened to be identified as PPH. Can you see that? They're not telling you the exact amount, because the exact amount is nothing but a rough guess. How do we make that rough guess about the ml of blood loss that happens in pregnancy? By obviously looking at the amount of blood loss that is pouring right in front of you, and also by using the amount of gauze pieces, the amount of mops that have been soaked up, isn't it? So that will give us an idea about how much blood loss has been going on. Now, see, the woman is getting decompensated slowly. She's having tachycardia, her BP is falling, so she's becoming symptomatic. So my diagnosis of postpartum hemorrhage is made. But what is the cause here? Is it a genital tract laceration? Is it retained placental bits? Is it atonic uterus, or is it uterine rupture? Flabby, yes, very good, Subhash. They're giving you the description here. Uterus is flabby. A flabby uterus meaning a relaxed uterus, right? So immediately soon after the delivery of the placenta, the uterus should immediately contract back. And moreover, we are following what in the third stage of labor? We are following active management of third stage of labor. So let's say after delivery of the baby, we had already given 10 units of intramuscular oxytocin. And if we are following active management of third stage of labor, then immediately after delivery of the placenta, the uterus should immediately contract. If that's not happening, uterus is flabby, your diagnosis is atonic uterus. Your diagnosis is atonic uterus here. Now the next thing is, what do you do next? So you are in this situation. Imagine yourself in this situation. You are conducting the delivery of a multiparous woman, and the placenta you have delivered completely, but the uterus becomes flabby. What do you do next? You are there in between the legs of the woman. You are conducting the delivery. The placenta is in your hands. You put that aside, and there's this gush of blood flow that you are seeing. How do you act immediately? Now there are protocols in place. There is a PPH drill in place that is inculcated in everybody who takes part in conducting deliveries, be it the nurses, be it the interns, be it the whosoever, the medical practitioners, whosoever is working in the labor room. So you have to, Janani has already said that she is going to start oxytocin. Rashmi is also saying oxytocin. So yes, you will start uterotonics. Yes, of course, but please do not forget that you in managing PPH, you are not the hero alone. Of course, you are the driver, but you are not the hero alone. So you will have to call for help, because who is going to get you the oxytocin? Who is going to inject the oxytocin? Who is going to start the IV bore line? Who is going to start the IV fluids? You need help of people around you. So you must have seen in labor rooms, and when I talk about PPH, I get all animated, and I get in a frenzy while talking about PPH, because I've seen that you always tend, students always tend to think in labor room mein itna shor kyun machta hai? Why is always this commotion there? This commotion is PPH is a situation where commotion can be created. And one good thing about that commotion is that a lot of people come to help you. So yes, so that is something that is recommended. So the clinical management of atonic PPH is, you need to call for immediate help. Do not forget that. And simultaneously a quick assessment. What is this quick assessment about? The quick assessment about the hemodynamic status of the woman. You talk to her, you ask her if she's feeling okay, attach the pulse ox, attach the monitor if there is there, otherwise ask somebody to quickly take the BP and the pulse rate measurement, right? So quick assessment of the hemodynamic status of the woman is very important. You call for help. The person who will come back is going to start two wide IV lines, wide bore IV lines, right, on one line. So two are required, mind you, two are required, because on one line you are going to get rapid infusion of IV fluids, right? So fluid resuscitation, right? And do not forget, 500 ml of saline, no, immediate you'll have to transfuse 1500 ml fast. 1500 ml fast will need to go. Send in the blood investigations. One person is going to immediately send in the hemoglobin sample, for the hemoglobin report. One is going to send the coagulation profile. One is going to send the blood group for cross matching, and one person is going to call the blood bank so that quick blood can be arranged. So arranging for blood transfusion is important. And one person who's come to help you is also going to catheterize the bladder. Why catheterizing the bladder is important? Can anybody tell me? Why catheterizing the bladder is important? Can anybody tell me? Call for help, Subhash, is a dictum in all obstetric emergencies. Call for help is your go-to response in all obstetric emergencies. Can anybody tell me why catheterizing the bladder is important? Well, catheterizing the bladder is important. You have to put in the Foley's catheter per urethra, and that will empty the bladder. See, the woman has been lying down in labor for a long duration of time. She is delivered. She was in the second stage a while ago. And there are times when the bladder is full. And full bladder interferes with the uterine contractions. How? Mechanically. There's a full bladder lying in front of the uterus. Behind there is a flabby uterus. So if the bladder is full, it mechanically interferes with the uterine contraction. So many times we realize that as soon as we empty the bladder, the uterus contracts. So catheterization of the bladder helps in that aspect. And secondly, this woman is possibly going into shock. She could go into shock. And management of any patient in shock, you have to monitor the urine output, isn't it? If you have to give IV fluids or blood transfusion to a person and you are monitoring a patient of shock, you have to monitor the urine output to take care of the input output, right? So that will also help. So that's why catheterization of the bladder serves two important purposes here. Right? So rightly said, Rashmi also gave the, Subhash and Rashmi, both of you, and Dr. Musarat also gave the right answer here. Now, the other important thing is that somebody is doing all this for you. These is the helpers that have come are doing all this for you, taking your orders because you're the driver, right? But what are you yourself doing? You are standing, you just conducted the delivery, you're standing there, you're just shouting orders. No. What are your hands busy doing? Your hands are busy doing bimanual uterine tamponade. Now, what is this bimanual uterine tamponade? It is not uterine massage. Massage is per abdominal. There is a different name for this. This is bimanual uterine tamponade. So one hand is inside the vagina in a fist form. One hand is inside the vagina in a fist form. The other hand is on the abdomen, per abdominally. And we are using both the hands to create a tamponading effect on the uterus and massaging simultaneously. So what have we done? We are opposing the anterior and posterior walls of the uterus so that the open venous sinusoids, they are opposed together and some compression is achieved and some blood loss is decreased, and rubbing up the uterus, when we rub the uterus, it also triggers contractions. So that is the goal of this bimanual uterine tamponade. And simultaneously oxytocin is Methergin is, you have to understand that the downside of Methergin is that it cannot be used in all the situations. So you have to keep the contraindications of Methergin in mind. So what are the contraindications of Methergin? Yes, what are the contraindications of Methergin? Methergin you can definitely give if there are no contraindications. So you have to keep the contraindications in mind. What are the contraindications? Like mother is having a Heart disease. So heart disease in the mother. Heart disease in the mother is going to be a contraindication. Methergine causes sudden severe hypertension as a side effect, so it cannot be given to women who have pre-eclampsia or eclampsia, right? Methergine is contraindicated if you have a second twin along the way. So in case of a multiple pregnancy, right, when you have a second twin on the way, if there is a second twin, then you cannot give methergine because the baby is still inside, so you cannot use it there. You cannot use it in Rh negative women, right? You cannot use it in peripheral vascular diseases because methergine causes intense vasoconstriction. So these are the contraindications of methergine that you need to keep in mind. What is the other drug there? What is the other drug there now? What else we have got in our armamentarium? We have misoprostol. We can use misoprostol 800 microgram per rectally. Okay. Yes, yesterday in the abortion the sections and everything, I was describing that misoprostol can be active through any of the routes, be it rectal route or sublingual route or vaginal route or oral route or whatever. But giving per rectally makes the most sense. Why? Because see, if you're going to tell me, if there's an examiner, he asks you that how will you give the misoprostol, you can't give it per vaginally, na? The tablet will flow out because the woman is bleeding, so you can't put it in the vagina. You want to give it sublingually or orally, the woman is bleeding, she is going into shock, probably she's lying like this exhausted, and you want her to swallow a pill or put something underneath her tongue, and risk of aspiration and everything. So it's better to give it per rectally. It's better to give it per rectally, right? So misoprostol 800 microgram per rectally is the dose that is given. We can also use carboprost 0.25 milligrams every 15 minutes, but for a maximum of 8 dosages. So these are the uterotonics which we can use. And remember one thing, when we have started oxytocin IV infusion, the uterus should respond immediately. So I've started the infusion, I'm doing the bimanual tamponade, uterus is not responding, I can feel that this uterus is still flabby, then I don't wait for the infusion to finish and then move on to the next drug. No, I don't do that. I have to act immediately. So I started the infusion, the uterus is not contracting, I move on and add another uterotonic agent. So if the contraindications are not there, I can use methergine, right? Otherwise, I can also put in a misoprostol tablet per rectally. I can ask the sister to give a carboprost injection 0.25 milligram. The route is intramuscular for carboprost. Another important thing, when will I not give carboprost? Do you have any contraindication for carboprost? What is the contraindication for carboprost? What is the contraindication for carboprost? Any contraindication for carboprost? Asthma. Very good. So contraindication for carboprost is asthma, right? Now, Dr. Musarrat, why not in Rh negative women? Rh negative women is a relative contraindication. It's not an absolute contraindication. This is a relative contraindication. It's not an absolute contraindication because it has been seen that when we give methergine, the uterus contracts very forcefully and some of the fetal blood remains that could be remain in the placental circulation, in the remains of the placental circulation can re-enter the maternal circulation and caused increased risk of feto-maternal hemorrhage. But yes, if the other agents there safely, misoprostol and carboprost can be used. Now, the next important thing that I want to emphasize here is very, very important. They have given here in the guidelines that carboprost needs to be given every 15 minutes for a maximum of 8 doses. Does that mean that before moving on to the next step, you have to exhaust all the 8 dosages? Answer me yes or no. If you are given that carboprost can be given for a maximum 8 dosages, does that mean that you have to exhaust all the 8 dosages before moving on to the next step? Yes or no? I want to hear from you. No. Yes, very good. No, it doesn't make sense. That's why assessment and resuscitation is so important at each step. You have given oxytocin. Let's say there were no contraindications. You gave methergin also. Let's say you gave misoprost also. You gave 1 dose of carboprost also. And your uterus is still flabby, it's not responding, then you don't have to exhaust 8 dosages to move on to the next step. So that is why continuous assessment is required, right? So when you are doing all these steps, how much time have you exhausted? Another 10 minutes, another 15 minutes at least. You give carboprost injection, you see some response maybe, wait for 15 minutes, give another carboprost injection, half an hour has gone by. If half an hour has gone by and your uterus is not responding, you have to immediately move on to the next step. Immediately move on to the next step. And now is a good time. Now is a good time to look for completeness of placenta. Let's ensure that the placenta that we removed was complete or not. It's quite possible that some placental bits or cotyledons or lobes, they may have been left behind, and look for any associated genital tract laceration which is contributing to the PPH as well. All right, so look for the completeness of the placenta also there at the same time, and then move on with the next step. What's the next step? What's the next step? What is the next step? Yes, before I change the slide, I want to hear what the next step is. What is your plan now? You have exhausted the uterotonics. What's your next plan of action? Tamponade. Tamponade. Where will you do this tamponade, Subhash? You want to do it in the labor room, or you want other people to come and help you and maybe take her somewhere and then do the tamponade? See, in PPH and in obstetric emergencies, we always think ahead because we are wasting time. If we are not thinking ahead, we are wasting time. So yes, I know that I have the option of tamponade available to me, but I have to think ahead, because what if my tamponade doesn't work? If my tamponade doesn't work, the next option is surgery. So ideally, I will again, Sapna rightly said, I will again ask for help. Whom will I ask for help? To the anesthetist, to the OT sister. I will ask for help from these people. I will send somebody or tell somebody to inform these people and tell them that I'm getting a patient with atonic PPH to the OT. I want things ready for me. All right, because if the tamponade fails, the next step is surgery. So what we are going to do, we are going to go ahead and do balloon tamponade, and this balloon tamponade should ideally be done in the OT. And if you yourself are in this position, make sure that you call a senior obstetrician, a senior person to help you out in this, right? And do not venture into doing a tamponade all by yourself. I mean, you can obviously mobilize. We will definitely mobilize, and we will again call for help. All right, so what is this balloon tamponade? This is balloon tamponade. So there are specially designed balloons which are available for tamponading, right? So this balloon on the left side that I'm showing you here, this is called as the Bakri balloon. This is called as the Bakri balloon, and it's a specially designed balloon for uterine tamponade in atonic PPH. This can be filled with saline, and the capacity is about 500 ml. All right, so we introduce this balloon inside the uterus in a deflated state. So we put this inside the uterus like this, okay, and we are going to fill it with saline. And the special design in this Bakri balloon is this outlet, is this tubing, is this outlet here, which does not allow any blood to collect behind, right? So this is that is the design in this Bakri balloon. All right, and yes, we here also need to remember this Bakri balloon is expensive. It's not available everywhere, so we can have an alternative design in place. So we have this jugaad that we use, that we call as the condom catheter. So this condom catheter can come in handy in situations where we don't have a Bakri balloon. And let's say, for example, that you were delivering this woman, she had PPH, you exhausted the uterotonics, and now she is you are in a peripheral healthcare center and you want to refer this woman to a higher center. So we do our bit. What do? That we do our can do this balloon tamponade using a condom catheter, so that some time can be saved, and some time can be given to the woman till the time she reaches the higher center. So again, we put this is a Foley's catheter, and around that Foley's catheter we tie a condom, and we inflate the bulb of the Foley's catheter so that it stays, and we put this thing inside. When we put it inside the uterus, we put it in the deflated state, and then we can fill this condom with saline as well. So the purpose is to give a tamponading effect to the uterus. It doesn't mean that you are not going to continue the oxytocin infusion. Please remember, we have not stopped the oxytocin infusion all this while. Don't say oxytocin one whack gone and then nobody has bothered to restart it. So please remember that oxytocin infusion also continues throughout, right? Now, if this condom works, if this condom catheter works, or if this balloon tamponade or Bakri balloon works, well and good. Otherwise, the next step is surgical methods. And Dr. Musarrat had rightly said B-Lynch suture. He said B-Lynch sutures are what he's going to prefer. I agree with him that the purpose of this B-Lynch suture or any suture, these are called as compression sutures. So when we talk about the surgical methods, we have two options available to us. We can go for the uterine compression sutures, or we can go for the stepwise devascularization procedures. So what are these uterine compression sutures? They are sutures which are applied on the uterus, and we want to compress the uterus. So when we compress the uterus, what are we doing? We are making the anterior and posterior walls of uterus come together and oppose. So we can apply these uterine compression sutures. One can use whatever one is trained in. Most of us are preferring to use the B-Lynch sutures. You should, as NEET PG aspirants, you should also be knowing that yes, there are other ways of applying the compression sutures also. They are Heyman sutures, they are Cho square sutures. Doesn't matter if the delivery has happened vaginally or by cesarean section, we can use these uterine compression sutures. I'll just give you a brief understanding of how they are placed, and that will make you just have to understand the concept here. So you can see here a suture is introduced and it is moved around and brought out like this, right? And then brought out here and then tied in the front. So this is how compression sutures are applied. And when we tie them, it compresses the uterus. This is the B-Lynch suture. This here is the B-Lynch suture. Then we can have Heyman suture also, where just two sutures like this, they are tied. Right, so you can see this is how the Heyman suture is tied. The goal is the same. That is to achieve uterine compression. All right, and uterine compression sutures, they work best with atonic uterus. So if the uterus is atonic, I will always prefer to use compression sutures. All right, and we can also move ahead and go ahead and do the stepwise devascularization procedure. Which vessels can be devascularized, or which vessels can be ligated step by step? We can ligate the uterine arteries. So this is your flabby uterus, or whatever, flabby uterus. This is where the uterine arteries are. You can ligate the uterine arteries at this location. So we have to ligate both the uterine arteries. The internal artery ligation can be done, and the bilateral ovarian artery ligation can also be done. It is done in a stepwise manner. All right. Now you can also understand that going ahead with the stepwise devascularization procedure one at a time is going to be time consuming. And that's why in the face of atonic PPH, most of us prefer to go ahead with uterine compression sutures. Once we have done the uterine compression sutures, then we can add stepwise devascularization procedures also, on top of that. But in the face of emergency, I want to do something that is quick, right? So I prefer a B-Lin suture. Most of us prefer B-Lin sutures there in that circumstance. And later on, we can add the stepwise devascularization procedures also. Right now, what if I have tried all this? What if I have tried all this and still the uterus fails to contract? Right? If I've tried all this and still the uterus fails to contract, I unfortunately might not be left with much of a solution but to go for a hysterectomy in that situation, right? So this is an unfortunate circumstance, but yes, women can land up in hysterectomy with atonic PPH also if we have tried the conservative surgical procedures and nothing is working. Then we can land up in a hysterectomy. Now, one thing to note about this is I'm telling you all the time that assessment and resuscitation continues. Assessment and resuscitation continues. So now it's been hours that a woman has been bleeding. So because of excessive bleeding, she potentially could have gone into DIC also, right? So her coagulation profile might be deranged by now. So the resuscitation protocol will not only involve infusion of blood products like packed cell volume transfusion also, but we'll also maybe need to give platelet transfusion and fresh frozen plasma transfusion. So the resuscitation protocol is going to follow the same lines as any hemorrhagic shock management follow. So when we have to give massive blood transfusion to somebody, we also have to give platelet transfusion. We also have to give FFP transfusion, fresh frozen plasma transfusion. So the resuscitation continues all along. But yes, there are times when after hysterectomy also we have closed up, we've removed the uterus and everything, and we realize that she might have landed into DIC and there's oozing from every side. Whatever sutures that I had placed, whatever incisions I had made, they're slowly oozing blood. That shows that maybe DIC is there. Then under extreme circumstances, I can put in a pelvic pressure pack. That's not always required, but if there is evidence of DIC or evidence of bleeding in the peritoneum, then I can put a pelvic pressure pack also. And this pelvic pressure pack can be removed at a later point in time, right? So this is about the clinical management of atonic PPH. It follows this protocol, right? Now let me talk about the devascularization procedures in a little bit more detail. So this is important. MCQs are asked on your stepwise devascularization procedure. So like I'd shown you, the uterine artery enters the uterus here. All right, just about 1.5 to 1 to 1.5 centimeters away from this cervix, and here it can be tied. So bite of the uterus is also taken and we tie it, and the ovarian artery can be tied at this location, right? So we can go for uterine artery ligation, we can go for ovarian artery ligation, and then we can go for the internal iliac artery ligation. So this is the common iliac artery, right? This is the common iliac artery, and we can see that it divides into the external iliac and the internal iliac artery, right? So the external iliac artery supplies goes and becomes the femoral artery later on. So we don't have to touch this external iliac artery. We have to ligate the internal iliac, but in the internal iliac also we have to ligate the anterior division. It is the anterior division of the internal iliac artery which supplies the genital organs, isn't it? The genital organs supply, that means the uterine artery, the vaginal artery, the internal pudendal arteries, all these arteries are branches of anterior division of internal iliac artery, and that is the branch that I have to ligate, right? Now, this internal iliac artery continues as the anterior division. It continues as the anterior division, and somewhere it gives the posterior division. Look at this. This branch here is what we call as the posterior division of the internal iliac artery, right? So this here is the posterior division of internal iliac artery, and we have to ensure that we don't ligate the posterior division, but we ligate the anterior division. So they ask you this question, that what is the site of ligation? How do we ensure that we are saving the posterior division? The posterior division needs to be spared. How do we ensure that? So to ensure that the site of ligation is somewhere about 5 centimeter, 5 centimeter, the site of ligation is somewhere around 5 centimeter, 5 centimeter distal to the bifurcation of the common iliac artery. By that we ensure that the posterior division is spared, and that is here we are ligating. So what is the site of ligation? About 5 centimeter distal to the bifurcation of the common iliac artery. That is where we are going to ligate this common iliac artery. Okay. Now, one another MCQ they ask in your exam. Which artery is never ligated during stepwise devascularization procedure? Which artery is never ligated in stepwise devascularization procedure? Yes. Internal iliac artery, yes, it is ligated. Uterine, ovarian, yes, it is ligated. But common iliac artery should never be ligated. By mistake, if you ligate the common iliac artery, you are going to make the lower limb ischemic. So that's not supposed to be done. So never by mistake ever ligate the common iliac artery. We have to make sure that we ligate the correct artery. That's the anterior division of internal iliac artery. We have to spare the posterior division, and that is ensured if we ligate the artery about 5 centimeter distal to the bifurcation of the common iliac artery. Okay, so this is important to note here. All right. Now, mind you, one thing I also want to tell you here is that this stepwise devascularization procedures, they are helping in atonic PPH, of course, but these are surgical methods which can be used to control bleeding from the uterus even without atonicity, isn't it? Even without atonicity, if the uterus is bleeding too much, even in gynae surgeries, sometimes if the uterus is bleeding too much, we can use the help of these devascularization procedures as well. So keep that in mind also. Now let's see the clinical questions. Let's see the clinical questions. So I've given you a flow chart of the management. Let's see how questions or what kind of clinical questions are asked and how we find ourselves in. So a 25-year-old woman delivered her first child vaginally and started bleeding profusely soon after delivery of the placenta. The placenta and membranes are expelled, but the uterus is atonic. You start bimanual uterine compression and have exhausted the uterotonics available to you in the labor room. Her pulse rate is 120 per minute, BP is 90/60, blood is on its way. What do you don't do? What do you don't do? Carry out balloon tamponade in LR, take patient to OT and perform balloon tamponade, take consent for hysterectomy or inform the consultant on call. What do you don't do? So you know what is bound to, you know what can happen, you know the consequences, and you are thinking ahead. So you have exhausted the uterotonics, she's getting decompensated, the uterus is still relaxed, blood is coming, blood doesn't hang in the labor room. It takes some time for cross match to happen, and it will take at least 30 minutes to come. So blood is on its way. You inform the consultant, you tell the consultant, madam, there is atonic PPH, I've tried everything, it's not working, I need to take her to the OT, please come. Right? So you take the patient to OT, perform the balloon tamponade there. If the consultant is late, you can do it yourself. Take consent for hysterectomy also, because you don't know what might happen once you've gone inside the OT. She can land up in a hysterectomy also. So you have to take consent for hysterectomy as well. But it would not be wise to carry out balloon tamponade in the labor room. So out of all these options, this is something that you won't do. Okay? Understand? Now let's move ahead and talk about the next clinical situation. Let's have a look at this. Now see, same woman, a 25-year-old woman delivered her first child by cesarean section. for arrest of labor, which you are assisting with your senior resident. So I've placed you in the OT with the senior resident. You are there, part of the cesarean section, you are assisting. The placenta and membranes are expelled, but the uterus remains atonic. Fluid resuscitation is begun. You start by manual compression and have exhausted the uterotonics available to you. So even when you are operating and it happens during cesarean section, the steps to manage the PPH or atonic PPH is the same. You still are doing with the now the uterus is right there in front of you, abdomen open, and you are doing bimanual uterine compression. Exhausted the uterotonics available to you. Pulse rate is still 120. BP is 90/60. 2 units of blood. It's on its way. What would be the most appropriate next step? What would be the most appropriate next step now? Yes, of course, B-Lynch sutures. B-Lynch sutures. There is no problem now. Why waste time with a tamponade and everything? I mean, even if a tamponade would have been given here, I would have chosen B-Lynch suture, because now the uterus is open. The abdomen is open, and I can quickly put a B-Lynch suture. So that would be your most appropriate step here. Why waste time with doing these internal iliac ligations and artery ligations? They are time consuming, they take time. Look at the status of the woman also. She is also decompensating. Look at the fact that the uterus remains atonic. Once I've placed the B-Lynch sutures, I can top it up with the artery ligations also. So I would, in this circumstance, prefer a B-Lynch suture over artery ligations as well. But there is one situation where I can choose a bilateral uterine artery ligation. Supposing we were doing this cesarean section and there was this bleeding, too much bleeding from the incision site. If there was too much bleeding from the incision site, but the uterus was not flabby, the uterus was contracting well, but still there was a lot of bleeding from this incision site. So that's our uterine artery here. That's our incision in the lower segment here. So in that situation, I could just ligate the uterine arteries, and that would do the job. So during cesarean section, when there is a lot of bleeding from the uterine incision site, one can use uterine artery ligation there. All right. Now, Subhash is saying placenta previa at term can also be cause of atonicity itself. See, placenta previa, no, when the placenta is still inside, how can it cause atonicity? But yes, when there is placenta previa, and those women with placenta previa, we do cesarean section on them, then in them, if there has been bleeding, antepartum hemorrhage, then they are more prone to develop atonicity after delivery. So placenta previa causing antepartum hemorrhage, it can lead to more risk of uterus being atonic after delivery of the placenta. Okay. All right, Subhash. Now let's see another cause. Too much about atonicity. Let's talk about another cause of PPH. Now let's say you're conducting the delivery of a 35-year-old primi gravida in spontaneous labor. A healthy 4 kg boy delivered. Placenta was delivered complete and intact. You have completed the episiotomy repair, but notice excessive vaginal bleeding. The pulse rate is 110, BP is 100/60, uterus is well contracted. What's the likely diagnosis? What's the likely diagnosis? Genital tract laceration, retained placental bits, coagulopathy, or atonic uterus. What looks more likely to you? Yes, Dr. Busarat and Janni are rightly saying it's most likely looks like a genital tract laceration, right? Placenta has been delivered complete and intact. That information is already given to you. So why there will be retained placental bits? Well, information is already provided that you've delivered the placenta complete and intact. The pulse rate is high, the BP is less, and the uterus is well contracted, so it is not atonic uterus. So the likely diagnosis is a genital tract laceration. It is not retained placental bits. Information is already given to you. Why is it not coagulopathy? I will like to think of coagulopathy later, isn't it? There is no risk factor here which gives the doubt about coagulopathy. There is no history of abruption, and there is no any history given of bleeding disorder or anything. So why would there be coagulopathy, right? And yes, good size baby, that's another reason why we are thinking of, and we've also given an episiotomy repair. But even then, whenever atonicity is not the reason for PPH, think about the second most common cause. If atonicity is the most common cause, then the second most common cause is trauma and laceration. So think about trauma in the next situation. Now, what kind of genital tract trauma could be there? Now, there can be varying types of genital tract trauma. We could have perineal tears. We can have perineal tears. We can also have vaginal tears. Okay. We can also have cervical tears. All right. Now, trauma is plain and simple. Look for the trauma, see the tear that is bleeding, and then suture back the tear. Isn't it? Look for the tear and suture it up. That's your solution to a genital tract trauma. So whenever we're thinking of trauma, it is imperative, necessary, essential to completely examine the cervix, the whole of the vagina, and the perineum. Nothing should be missed out. It doesn't matter you are seeing a tear in the perineum, so you stitch the perineum, right? And then you don't look inside. Don't bother to look inside. Don't bother to look at the cervix. No, a complete cervical and vaginal exploration should definitely be done. Maybe there are more tears, right, which should not be missed. So a complete evaluation is imperative in a genital tract trauma, and these are the varying types of perineal tears which we can identify. MCQs on perineal tears are asked in the NEET PG examination as well. So let's have a look at these tears. See, in the mildest form, the mildest form of tears, we have the first degree perineal tear. This is the first degree perineal tear, where we can see that the skin and the mucosa are torn. We can have a second degree perineal tear, this one here, where apart from the skin and the mucosa, the perineal muscles are also torn. So it's deeper. In fact, episiotomy is a type of second degree perineal tear only. Episiotomy is an incision that is given by us on the perineum. And in that we cut the skin, the mucosa, and the perineal muscle. So episiotomy is a obstetrician induced. It is a surgeon given second degree perineal tear. And then there can be a third degree perineal tear where the anal sphincter is also torn. So we can have three types of perineal tears, three types of third degree perineal tears, A, B, C. So we can see here that in the first degree, 3A, here 3A, less than 50% of the external anal sphincter is torn. In 3B, we can see that more than or equal to 50% of the external anal sphincter is torn. And in 3C, we can see that the external anal sphincter is torn completely, and along with that, the internal anal sphincter, this one here, this white line, this white sphincter, glistening white tissue, that internal anal sphincter is also torn. That is the 3C type of perineal tear. And we can have a fourth degree of perineal tear. What is the fourth degree? This is your fourth degree of perineal tear, where even the rectal mucosa is torn. So these are the various types of perineal tears that we can identify. The third degree and fourth degree perineal tears together, the third and the fourth degree perineal tears together, they are called as OSS. What is the full form of OSS? Obstetric anal sphincter injuries. Obstetric anal sphincter injuries. This is what the term OSS means. Now see, the first and the second degree tears you can repair in the labor room, no problem. Episiotomies we routinely repair in the labor room itself. But for the second and third degree perineal tear, they should ideally be repaired in the OT under adequate analgesia and anesthesia, and under proper lighting and vision and comfort, and so that the proper lithotomy can be made and everything. So for the third and fourth degree perineal tears, they should ideally be repaired in the OT, because mind you, if we don't repair these tears properly, external anal sphincter repair, internal anal sphincter repair, rectal mucosa repair, if not done properly, can have long-term consequences, some consequences like inability to retain flatus and feces, so that incontinence can develop at a later point in time. So it's better that we repair these obstetric anal sphincter injuries ideally in the OT under adequate analgesia, anesthesia if required, and under expert or senior guidance and supervision. All right. Now, moving on further, such kind of questions are often asked in your exam. This is an often repeated question. A postpartum woman comes to the OPD with a complaint of involuntary passage of flatus and feces. She had a home vaginal delivery 3 days ago. On examination, there's a complete perineal tear. The fourth degree perineal tear is often called as the complete perineal tear also. When should the repair be done? Should you repair it immediately? She had a home vaginal delivery 3 days ago. Should you repair it immediately, 1 month, or after 6 weeks? When should the repair be done? So in the previous situation where we were discussing, I told you that when you are conducting the delivery and when you have identified the laceration immediately, it's repaired immediately. So when we identify the tear, immediately during delivery, it should be repaired stat. It should be repaired at the same time immediately. But if the identification of the tear is delayed, now under what circumstances the identification of the tear will be delayed? Of course, if she's not been delivered by you. If you are cautious and you are delivering the woman, I will not leave a woman's side until I'm sure that she is not bleeding, there's no problem, there is no trauma, nothing, right? And so under good scenarios and under situations where you are conducting the delivery, if the tear has happened during the delivery, there's no forgiving if you're not able to identify a tear then. But yes, under circumstances when she had a home delivery and somebody else conducted the delivery, then she can come back at a late point in time, and then you have to repair after puerperium, right? So any repair should not be done in the puerperium period. During that period, the uterus and the genital tissues are involuting, they are repairing themselves. In that reparation process, there's a lot of lymphocytic infiltration in that space. You have to understand that any healing in that complete perineal tear area, any healing takes place by, first of all, by inflammation and then by fibrosis and scarring. Now, if in that inflammatory state we are going to take sutures and try to repair the tear, then the repair will not hold. It will not hold properly, it will be unsuccessful, and successful repairs are seen to be done after puerperium, right? So you have to do it after puerperium. Keep that in mind also, right? Now let's move on to the next cause. Let's move on to the next cause. Now there's a primary gravida and she had an uneventful vaginal delivery of a healthy 3.5 kg baby boy. After about an hour, she complains of excessive pain at the episiotomy site and inability to pass urine. Pulse rate is 110, BP 100/60, uterus well contracted, no complaint of excessive bleeding, no complaint of excessive bleeding. What is the likely diagnosis? Retained placental bits, atonic uterus, genital hematoma, or cervical tear. What is the likely diagnosis? Excessive pain at episiotomy site, inability to pass urine, pulse rate high, BP low. Signs of What? Blood loss. So blood is getting lost somewhere. Uterus is well contracted. So atonic uterus is not there. No complaint of excessive bleeding. That means no, the visible blood loss is not there. So it's not a cervical tear. If there would have been a cervical tear, it would be leading to visible blood loss. Retained placental bits. Retained placental bits can contribute to atonicity. Retained placental bits will contribute to intermittent atonicity. Intermittent atonicity, and there will be increase in vaginal bleeding, isn't it? Blood will be visible blood loss will be there. So it is not retained placental bits. So what it is genital hematoma, and she is giving you pointers like excessive pain at episiotomy site, inability to pass urine. Why does this happen? Because the location of the hematoma is such. The location of the hematoma can be in the vulva. We can have a hematoma in the vulva, it can be a vulval hematoma, or we can have it in the vagina, that is a vaginal hematoma. The location of the hematoma is such that it can compress the urethra, and then it can lead to inability to pass urine. This pain is excessive, excruciating pain at the episiotomy site or at the hematoma site or at the perineum. That pain in itself can lead to inability to pass urine as well. So now the next thing is you have to examine the local vulva. So on local examination, in the same case, there's a large swelling on the vulva. What is the management? Can you see here? Can you see here? This is a Foley's catheter that has been introduced to let the woman pass urine or to catheterize the bladder actually. And you can see the location of the hematoma is such that it is compressing on the urethra, and that's why there's going to be inability to pass urine. So what is the management? Wait and watch. Cold compresses for the pain, drain the hematoma in the LR, resuscitation and drainage of the hematoma in OT under anesthesia. This is a huge hematoma. This space can, there have been times when 500 ml of blood can also collect inside this vulva. So that is what, and look at the clinical status of the woman, pulse rate and BP. Right, so she is on the way to getting decompensated. So you'll have to start with the resuscitation, and please don't start draining the hematomas in the labor room. Ideally they should be done under adequate positioning, adequate pain relief, and they should be done in the OT under anesthesia. Right, so resuscitation and drainage of the hematoma has to be done in the OT. We'll give an incision over the hematoma, open it up, scoop out the blood clots that have collected. But that's not all. This blood has collected because some blood vessel inside is bleeding. So you'll have to identify the bleeder vessel, also, and ligate it. We'll have to identify the bleeder vessel also and ligate it. So just drainage of the hematoma is not enough. You have to identify the bleeder vessel and ligate it also. Right? Okay. Now let's move on further. Let's have a look at the next situation. There's a primary gravida who had an uneventful vaginal delivery, again of a healthy 3.5 kg baby boy. I'll read it fast because it's the same this thing. But after about an hour, look, uneventful vaginal delivery, no problem. After about an hour, she got up to pass urine and collapsed immediately. Okay, she looks extremely pale. You run to her. She collapsed right in front of you in the toilet. You go to her, run to her. She looks extremely pale. Pulse rate is 120. BP is 80/50. You put a hand immediately on her uterus to check if the uterus is flabby. You see that the uterus is well contracted. There is no bleeding from vagina. Bleeding from vagina is within Lomond limits. So you've looked. Doing a local examination, you find there is no swelling on the vulva. What is the likely cause? What is the likely cause now? Retained placental bits, atonic uterus, genital hematoma, or a cervical tear. The same options, a little different clinical scenario, but what is the likely diagnosis now? Retained placental bits, atonic uterus. The uterus is well contracted, so it's not atonic uterus, right? The bleeding from vagina is within normal limits. It's not cervical tear. It's not unlikely to be retained placental bits. There is no swelling on the vulva. There is no swelling on the vulva. Doesn't mean that there cannot be a vaginal hematoma. There can still be a genital hematoma. It could be in the vagina because we have just done the local examination. The uterus is well contracted, bleeding from vagina is within normal limits, and there is no swelling on the vulva. The next step in this situation is to do a PV. To do a PV examination. The moment you put a finger inside the vagina, you can feel a vaginal hematoma also. So it could still be a hematoma. I told you with retained placental bits, the uterus will be intermittently relaxed, right? And there is going to be visible bleeding in cervical tear. If there's a cervical tear, if there is a tear on the cervix, okay, there's this tear on the cervix and it's bleeding, there should be visible bleeding, isn't it? Why should there be bleeding from the vagina? Should be within normal limits, okay? So keep that in mind. It could still be a genital hematoma. It could be a vaginal hematoma. Right? Now, let's identify the next cause. A second gravida, para 1 woman with a previous cesarean section had a normal vaginal delivery. This time she had a normal vaginal delivery of a healthy 3.5 kg baby boy. She complains of excessive vaginal bleeding and abdominal pain. She looks extremely pale. The pulse rate is 110, BP is 90/60. So she's losing blood. She's becoming decompensated. She's becoming hemodynamically unstable because of that. The uterus is well contracted. There is no swelling of the vulva. Vagina is seen coming out of the internal os. What is the likely diagnosis? Retained placental bits, atonic uterus, cervical tear or uterine tear. What is the likely diagnosis? Look at the whole clinical picture. I have highlighted the clincher points for you here. What could be the likely diagnosis? Subhash is rightly saying uterine tear. Uterine tear. Why are you not thinking of a uterine tear? She has a previous cesarean section. She delivered vaginally. Okay. And after that, she is complaining of excessive vaginal bleeding. She's looking extremely pale. That means she's losing significant amount of blood. The uterus is well contracted, so it's not atonic uterus. Okay, so atonicity out. You start thinking about the next thing, that is trauma. What do you see in trauma? You see the vulva, no problem in the vulva. You explore the vagina and cervix also. Cervix and vagina all clear, no tear laceration identified. But you are seeing bleeding coming out of the os, blood trickling out from the os. It could be a trauma higher up. It could be a uterine tear which is bleeding. So previous cesarean section, in this question, the history of previous cesarean section also points to a uterine tear. Okay, cervical tear, it is not there because cervical exploration shows no laceration or hematoma. In retained placental bits, yes, I can understand your doubt that retained placental bits could also be a possibility. It could definitely be a possibility, but with retained placental bits, the uterus is going to be intermittently relaxed in between. And in this question, because there is a history of prior cesarean section, I would think more likely chances of a uterine tear because of the history of prior cesarean section. However, I agree that retained placental bits is also a definite possibility, but in choosing the answer, I will think of uterine tear more likely because there is a history of prior cesarean section and because it is given that the uterus is well contracted. With retained placental bits, there might be intermittent relaxation of the uterus as well. All right. Now let's talk about the next situation. All right. Now let's have a look at this. A woman came to the emergency with heavy bleeding 24 hours after vaginal delivery. Now she has come with secondary PPH. And now I know the most common cause is retained tissue. Okay. So what is the likely cause? battledore placenta, velamentous placenta, succenturiate placenta, or a circumvallate placenta? What is the likely cause? Yes. Now, I'll wait for the response here. I want you to know that placental abnormalities is a very, very important topic as far as NEET PG is concerned. For those of you who are going to practice in the future or are practicing right now, it is important to know that there are situations. There are situations where can be placental abnormalities, and they can present. They might create no problems at all but they can present at a later point in time with secondary PPH. So what is the likely cause in this situation here? Yes, very good. It's a succenturiate placenta. So what is a succenturiate placenta? Succenturiate placenta means an extra lobe. An extra lobe, an accessory lobe along with the main placental tissue. So this here is a succenturiate placenta. This is a succenturiate placenta. You can see this is the whole placental bulk, and there are small lobes, additional lobes here, which are attached to the main placental body by this leash of vessels. Now you can understand that if such a big lobe remains inside the placenta, succenturiate lobe, if this lobe were to remain inside, if this lobe remains inside the uterus, then it will hamper the uterine contractions. Mechanically, it will not let the uterus contract properly. So it can lead to atonic PPH also. Right? But if small bits are retained, small lobe or bits, they are retained, then the uterus can contract at that point in time. It manages to contract, but at a later point in time, it can intermittently relax, and between it will present as secondary PPH, right? It can present as secondary PPH. Also, it can get infected also. It can get infected secondarily. Secondary infection can happen to those small bits, right? So this is how they are going to present with secondary PPH, this succenturiate lobe. Right? Now, about the other abnormalities in the question, what is a battledore and a velamentous placenta and circumvallate placenta? How are they going to present? Let's just talk about that in brief also, just to show you that this is what we call as a battledore placenta. This is what we call as a battledore placenta, where the umbilical cord, instead of attaching at the center of the uterus, is attached at the center of the placenta, center of the placenta. Instead of attaching at the center of the placenta, the umbilical cord is attached at the periphery, but to the placental body. So what can happen is that when we are conducting the delivery of the placenta, when applying traction on the umbilical cord and pulling, it can lead to avulsion of this umbilical cord from its attachment, and then that can precipitate PPH. So battledore placenta can also precipitate PPH, but it will do so, immediately if avulsion of cord happens. Otherwise, no. And what is this abnormality here on the other hand? This is what we call as a velamentous placenta or velamentous cord insertion also. Velamentous placenta or velamentous cord insertion. So what happens in this is, you can see here that the umbilical cord, instead of attaching to the placental body, is instead attached to the membranes, right? And the branches, look at these branches, look at these umbilical vessels. These umbilical vessels, they are unsupported by the umbilical cord. This is the umbilical cord, right? Now the vessels, umbilical vessels are inside the umbilical cord, and there's this protective connective tissue covering, which is called as the Wharton's jelly. So that prevents the umbilical vessels against compression and twisting and rupturing and so on and so forth. So these vessels here, these are the fetal vessels. These are the fetal vessels which are running along the membranes. Right? Now these fetal vessels can get compressed during pregnancy also, because of the fetal part compressing on these vessels, or during the delivery of the placenta, when we try to deliver the placenta by pulling at the umbilical cord, we can avulse the umbilical cord from its attachment, and that can precipitate PPH. So velamentous placenta can also lead to PPH, but then again it would happen immediately after delivery of the placenta. Cord gets avulsed. And there is another very peculiar presentation of velamentous placenta. Can anybody tell me what that peculiar presentation of velamentous cord insertion is? Yes. Can anybody tell me what that peculiar presentation of velamentous cord insertion is? Yes. Anybody? Okay. So I'll tell you what that is. A peculiar presentation of this filamentous placenta is what we call as vasa previa. We call it as vasa previa. So you can look here in this figure I'm showing you. You can look here in this figure I'm showing you that this is the placenta and the velamentous insertion is there. You can see that the umbilical cord is ending here and these are the fetal vessels. These are the fetal vessels that are attaching to the membranes. And now these fetal vessels which are attached to the membranes, they are running over the internal os. Can you see? Yes. So they are running over the internal os, can you see? And it is here because it is called as vasa previa. Why? Because these vessels are overlying the internal os. So these are the fetal vessels which are overlying the internal os, isn't it? So these vessels, they can get torn. When will they get torn? Let's say during labor. During labor, when the cervix will start to open up, the uterus will start to contract, the cervix will start to open up, or with rupture of membranes, right? So during labor, what can happen with opening of the cervix, with cervical dilatation, or with rupture of membranes, these vessels, these fetal vessels, they are unsupported by the umbilical cord. The fetal vessels can also rupture. And the bleeding that will happen is, mind you, is fetal bleeding. These are fetal vessels. And that is why in this situation, the woman will present with vaginal bleeding during labor or with rupture of membranes, and there will be fetal distress. So I've described all of these abnormalities to you because they present differently. Okay, so these placental abnormalities have the potential of presenting differently in different clinical situations. All right. So the last abnormality that I want to talk about is the circumvallate placenta. If it's a circumvallate placenta, what's a circumvallate placenta? In a circumvallate placenta, there's this double fold. Can you see this? This double fold of amnion and chorion at the margin of the placenta is there. Okay, so this is what we call as a circumvallate placenta. Now behind this double fold of amnion and chorion here, there is this fibrin deposition. Okay, there's this fibrin deposition behind that. Now this fibrin deposition can precipitate future abortion, future chances of abruption in the pregnancy where the circumvallate placenta is there. So circumvallate placenta presents differently. It can present with antepartum hemorrhage, it can present with abortion, it can present with intrauterine growth retardation. So circumvallate placenta does not present with PPH, but it presents with APH, antepartum hemorrhage, or abortions, or IUGR. So these are the various placental abnormalities which you need to know. All of these abnormalities are important as far as NEET PG exams are concerned, and you need to know how they present in different clinical scenarios. And uterine inversion is a session that I have taken separately in the last week, so I'll skip the uterine inversion part here. So any doubts, any questions, feel free to ask me. I'll take up your doubts. You can type in the chat box here. I'll look it up. Any doubts, any queries, and feel free to visit the Unacademy platform, and you can find me on the free live classes there. In the last week, I have discussed all aspects of normal labor and abnormal labor there also. Sumant, I have not read anywhere what is the minimum blood loss in episiotomy. I'm so sorry, I'm not able to answer that question for you. That what is the minimum blood loss in episiotomy? How can I mean? I have not read it anywhere. I have not quantified it. I have not come across a study where somebody has tried to study how much is the minimum or maximum blood loss in episiotomy. It is irrelevant. Even if a episiotomy is bleeding and you are taking an hour to suture the episiotomy, and in the process 500 ml of blood loss has happened, then it's pph, isn't it? Okay. And Subhash, you're asking how IUGR occurs. Well, IUGR occurs because of this fibrin deposition. This fibrin deposition, which happens in the space behind the placenta, what it does is that it predisposes to a space, a portion of the placenta, which becomes unavailable for the exchange between the mother and the fetus. That's some small spaces in the placenta, because of this fibrin deposition, they become unavailable for the gaseous exchange between the mother and the fetus, right? So in the intravillous spaces, if there's going to be fibrin deposition, how the exchange of oxygen is going to take, and nutrients going to take place between the mother and the fetus. So that is why I highlighted on this fibrin deposition. It can explain all of these consequences. Okay. Dr. Musarat, methods of a perineal tear repairs. Well, perineal tears are repaired. Okay, that's an interesting question. Maybe where should I write? Any blank slide? Let's go to the perineal tear section and talk about the perineal tear repairs. Well, first of all, what the suture that we use is, the suture that we commonly use is Vicryl. Okay. And we have to use it, the thinner numbers will be used for the rectal mucosa and the internal anal sphincter. The important point that I want to tell you is, of course, if you have to stitch this perineal tear, a complete perineal tear, you will stitch, let's say this one, let's talk about this one. You will stitch the rectal mucosa first, then you will stitch the internal anal sphincter, then you will repair the external anal sphincter, and then the rest of the repair will be like episiotomy. So you will go from the rectal side repairing to the vaginal side, isn't it? Now, when we are repairing from the rectal side, we have to just be careful that the knot, of course, when we are tying the knot, when we are tying the suture and we are tying the knot has to not be towards the rectum. It has to be towards you, right? Of course. So the knot has to not be towards the rectum, but has to be towards you. Now, the most important aspect of this repair, on the other hand, is how to repair the external anal sphincter. There are two techniques. We can go for end-to-end anastomosis by suturing, or we can go with the overlapping technique. We can pull the two ends together and overlap them and then stitch them, or end-to-end anastomosis can be done. You ask me which is better. The latest evidence is that both are comparable. Both are comparable, equally good and effective. None is better than the other, but most of the times what we prefer to do is the end-to-end repair. Okay. Most of the times what we prefer to do is the end-to-end repair. So once we have repaired the external anal sphincter also, then we are going to put sutures on the muscles here. Muscle layer is going to be repaired, and then the mucosa and the skin is going to be repaired. Now, there are various people do various techniques. Okay. I am not saying any technique is good or bad. I mean, in the sense that one likes to take continuous sutures all the way. One likes to take interrupted sutures in the muscles, right? So usually what is recommended is to take continuous sutures. But yes, people can repair the muscle layer in interrupted sutures also, and then the mucosa and the skin can be repaired in continuous sutures, can be repaired in interrupted sutures. Cuticular stitches are also applied. So that varies from place to place. Dr. Musarat, I was describing a complete perineal tear repair to you. Whatever you have to repair, see, if you have to repair a complete perineal tear with the rectal mucosa injury, you'll have to repair the rectal mucosa first, then repair the internal anal sphincter. Otherwise, if you stitch the mucosa first, if you stitch this layer first, how are you going to go deeper and then repair the rectal mucosa? Right? So that is that sequence of repairs. And the end-to-end anastomosis and overlapping anastomosis, I'm talking about the repair of the external anal sphincter there. Okay. All right. Subhash, cuvular uterus, you are asking how is cuvular uterus managed? Cuvular uterus is managed if the cuvular uterus is a complication with placental abruption, right? And if we are identified cuvular uterus, usually we are going to identify during cesarean section. During vaginal delivery, it's not possible to look at the staining of the uterus with blood tissue, right? So the situation where we are going to identify a cuvular uterus is during cesarean section, if we have done a cesarean section in the case of placental abruption. Now, if we look at a cuvular uterus, it might look very ugly to you. Doesn't mean that it needs to be removed. The management is going to be under conservative lines. This cuvular uterus can have a propensity for atonicity. Then the management is of atonic PPH. There is no management of cuvular uterus per se. There is no management of cuvular uterus per se. If there is atonic PPH with the cuvular uterus, you manage the atonic PPH. Okay. All right. Anything else? If there are no further doubts, I'll take your leave now, guys. So join me for the plus course that's starting today. You can join me. Feel free to join me on the capsule course on reproductive gynecology. It's a plus course. It's on Unacademy platform. And all your requests, I am noting down all your requests, and I will be taking up sessions always on YouTube that are going to go ahead. And for the Unacademy subscription, you need to subscribe to the platform, and you can avail a discount of 10% if you subscribe using my code. So have a good day, friends, and see you tomorrow, same time. Thank you. Bye bye. Take care.